in the rooms. Hi, everyone. Thank you for being here. We're going to just wait a minute while people join us, and then we'll get started. Welcome, everyone. We're going to get started in just a minute, maybe. We'll wait for some more people to join us, and then we'll get rolling. Alrighty, I'll just go ahead and get started. Today's topic is on atopic dermatitis, JAK inhibitors, and beyond. Atopic dermatitis and eczema are often used interchangeably, but there are subtle differences between the two conditions. Learn how they're different and how atopic dermatitis can be treated with topical steroids, therapies, systemic therapies, biologics, and JAK inhibitors. It is my pleasure today to introduce our speaker, Dr. Clint Dunn. Dr. Dunn is a board-certified allergist in pediatrics and allergy and immunology. He trained at Children's Hospital of King's Daughters for his pediatric residency and fell in love with the specialty of allergy and immunology after working in the allergy division at CHKD. He moved to the Pacific Northwest after that and was thrilled at the recent opportunity to return to Children's Hospital of King's Daughters. He sees a full spectrum of conditions, including asthma, eczema, food allergies, hives, swelling, immunodeficiency, and immune dysregulation. He strives to incorporate evidence-based recommendations in evaluating and managing allergic and immunologic conditions. Thank you for being here today, Dr. Dunn. I'll turn it over to you.
Thank you so much, Linda. So just like Linda said, my name is Dr. Dunn. We're going to kind of talk through the JAK inhibitors and systemic therapies for atopic dermatitis. So this is my disclosures, none that are really pertinent to this lecture. Throughout this webinar, at the end of this webinar, hopefully we'll be able to all describe the fundamental features of atopic dermatitis, the treatment options for atopic dermatitis, and the ideal patient for each therapy as we kind of go along. So I think it's always important to start anytime that you talk about a disease state, talk about therapies from a provider standpoint, is understanding the basics of a disease. And so just like Linda said, a lot of time eczema and atopic dermatitis are thrown together and are mentioned in the same sentence. There is a difference. And so I am going to make sure that I am as specific as possible. Eczema is a generalized term. It is a description of the skin that means red, itchy, it means dry. And there's many kind of subsets of eczema, with atopic dermatitis being one of the most common subsets. Sometimes you'll see it called atopic dermatitis or atopic eczema. Atopic dermatitis is a very complex disease. And so it's an inflammatory condition of the skin that can affect the whole body. And it starts with skin barrier dysfunction, which with genetic reasons, with environmental factors that kind of causes a dysfunction in the outside layer of the skin that will increase the transepidermal water loss across the skin barrier, that will then signal from the skin that it's under attack, that it needs help, to try to help itself, to call attention to that location, to cause itch, that will start an itch scratch cycle, which perpetuates the signaling downstream to then call the immune system into the skin and cause dysregulation of the skin and the skin barrier, and a dysbiotic change, or kind of a change of the skin microbiome to a tendency towards different bacterial species. And so because of the complexity, it is important for us to treat across the spectrum as far as atopic dermatitis goes. And so a little bit more of some background as far as epidemiologic data. 13% of children are affected by atopic dermatitis, 7% of adults, with the vast majority of patients presenting or having onset of symptoms prior to 5 years of age. And 70% of patients do have remission by adolescence, but that remission does kind of differ for each individual. There is an equal distribution with different genders, different races and ethnicities. And because of the differences in the skin texture makeup, there is a spectrum of severity. So from mild to moderate to severe disease, to location, where some people it's only in the creases, or some people it is more head to toe. And there are some phenotypes that are underlying the underlying skin changes, and as well as endotyping, which are molecular changes that kind of cause the inflammation. That's important to understand when you're talking about therapies that we can try to do. There is a progression with atopic dermatitis where it starts out as a skin barrier dysfunction and then does progress to involve multiple disease states, including asthma, allergic rhinitis, food allergies. And they don't always have to be a straight linear progression or a progression from atopic dermatitis to food allergy to asthma to allergic rhinitis, but it sometimes can skip different options and show itself in different things. So I always love this picture. So this was from a lecture that was given during my training, and it's something that's always kind of stuck with me, is that eczema really is, in this case, we're talking about eczema, atopic eczema. It's the itch that rashes. So it really starts at the skin barrier where there are dysfunction in the skin barrier, in the stratum corneum, where the skin cells are going to click together. And instead of clicking together correctly, they are further apart because the tendrils that kind of help tie the skin cells are missing or defective. And that leads to water loss, which starts an intensely itchy process, and then it will progress from there. And so I would not be doing my job adequately if I wasn't going to talk about kind of pathophysiology, just to think for a second, because there's different phases of atopic dermatitis. And that's one of the reasons why it's been harder to kind of design specific therapies for it, is there's acute phases of atopic dermatitis and then chronic phases. So whenever there's immune dysregulation, it's a cascade where it starts a domino falling that progresses down to signal for help, to signal from the skin barrier, from the impaired skin barrier down that it needs help. And then it skews that inflammation as it progresses towards an allergic type, or kind of an allergic endotype that will then perpetuate itself to then cause other allergic disease, and then also impairment of the skin. And then it progresses after a period of time from an acute disease to a chronic disease. And so when we talk about therapeutics, we're going to dive into some of these mechanisms that we think about for both acute and chronic diseases, acute or chronic atopic dermatitis. But it's really important for us to understand the basics as far as how we can actually help take care of them. And it's also important to say, this is something that is a big topic in the atopic dermatitis, is that it is different for each ethnicity. So it's not a one size fit all that you can actually think that you can actually approach people, and you can actually approach each individual across ethnicities, across genders, and say, hey, this is the only way. There are similarities in the inflammation that is seen. There is similarities in the cell types that are seen, but the extents that you actually see them, the dysfunction, the thickness of the skin, and the barrier proteins that are affected are different for kids or for pediatric atopic dermatitis, as well as individuals who are of Caucasian descent or of Asian descent or of African American descent. And so instead of having a one size fit all, we really have to be much more targeted into actually how we treat this disease state. And it is a systemic disease that can cause many, many implications. And it's not just allergic. There are many different underlying lymphocytic changes that you can see. We call them, we number them based off of the type of lymphocyte that is affected. So you'll see Th2 or the allergic phenotype, but there's also a Th22. And then in some people, there's a Th17, which is also thought to be more of a regulatory aspect. And so we will kind of talk through some different aspects. And so since the major point of this talk is to talk about the JAK, the newer JAK molecules that we actually will think about, I will mention here kind of the JAK signaling. So when you actually look at the cytokines, or kind of the signals from the skin that it needs help, to kind of call the immune system to the party, those signaling mechanisms have to start from one position and go to the next cell. And so to do that progression, you actually have to have, just like a domino kind of falling down kind of progressively, it has to start as a ball that lands into a receptor or kind of into a glove, and that glove has to then signal through. And so all of our cytokines, or the vast majority of our cytokines, whether they're inflammatory or allergic, or kind of the different pathophysiologies that we think of, every single disease state is signaled from a cellular standpoint. The vast majority are signaled through what are called JAK, Janus kinase. Janus kinase is named after a Roman god of two faces because it requires two signals that come together. And then those two signals on the inside, which are kind of what you see at the bottom there, kind of on the left side, that talk about the different JAKs. They are what perpetuates the signal to the nucleus to actually cause transcription or cause us to make proteins that will actually have further implications. And so when we actually look at the different medicines that we're going to be trying to treat with, it's important to know where in that process they actually affect. And there are different Janus kinase signaling mechanisms. So there's Janus kinase 1, 2, 3, and then another one that is called a TYK2 or TYK2. And so there is different processes. But our immune system has some level of redundancy in it so that it can actually affect itself in different ways depending on which molecules we recruit. And so we have to find a delicate balance of decreasing the allergic cells, but then also not affecting our immunologic function. And so trying to find that delicate balance is one of the biggest things that we are paying close attention to. So anytime that we talk about atopic dermatitis, we have to talk about the basics. And the basics really do start with a skin hydration issue. And so I told you that it is a skin barrier dysfunction that leads to transepidermal water loss. So the skin is porous, the skin is more open, just like a sponge. That sponge dries out, and so we have to restore moisture into the skin. If you ask 10 different dermatologists, 10 different allergists and immunologists, you're going to get 10 different answers on the appropriate way of going. But ultimately, it is a hydration standpoint that we start out making sure that we focus on what are we doing from a bathing perspective, from an emollient or kind of a moisturization perspective, and then we avoid irritants, allergens to the skin that can actually cause it. And then the mainstay of therapy for atopic dermatitis is our topical corticosteroids. And so topical corticosteroids have a lot of utilization, and they're the most commonly used therapies for the skin. They do sometimes get a bad rep. We number steroid potency between 1, which is the strongest, or the most potent, 7, which is the weakest, or the least potent. Every single guideline that we look at, from the American Academy of Dermatology, as well as to the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology, strongly recommends the use of topical steroids in different potency strengths. And it is important to understand, as a provider, where are we applying the topical steroids to, how long we're using it for, and what is the kind of the underlying skin texture that we're actually applying it to, because I'm not going to use the same strength of steroids on the face that I am going to use in the creases that I'm going to use on exposed skin, or kind of in skin that actually kind of folds and creases over each other. So you do have to know the difference. And there is different ways of approaching it. There's acute and burst therapy for significant acute flares, where you actually have to treat to kind of calm down the inflammation that's in the skin. But then also, if it's transitioned from an inflammatory disease to a chronic disease, you don't treat that the same way. And so you have to have a different approach as far as how frequently you're using it. And so there's, acute burst maintenance, which we'll talk about, using it twice a day until the skin clears, and then of different potency strengths, and then kind of backing off to maintenance, which some of our mid to low potency steroids are starting to have evidence to support maintenance use, which is for areas that are chronically inflamed, keeping that area clean by kind of using it a little bit more consistently to try to help in that. But making sure that we don't find that our aspects on the adverse side, which is related to too strong of use of thinning the skin, of actually causing stria, or kind of like stretching of the connective tissue, and kind of finding that delicate balance of not overdoing it without underdoing it is really one of the hardest aspects when you talk about the topical steroids. The next most common medicine that's used from a topical standpoint is the topical calcineurin inhibitors. So these are steroid-sparing agents. There's 3 available options. They are approved down to 2 years old. The 2 medications are pimecrolimus, which comes as a cream, and tacrolimus, which comes as an ointment. The pimecrolimus cream is approved down to 2 years old or 2 years and above. And then the tacrolimus is approved as 2 different strengths, a 0.3, which is 2 years and above, and 0.1. 0.03 is approved down to 2 years old. 0.1% is approved down to 16 years old. There is an efficacy difference. So the higher tacrolimus dose is more potent than pimecrolimus, but that is more potent than the lower tacrolimus dose. They're about equal whenever we compare them. They're about equal to the mid to low potency topical steroids. And so they do have the ability to be used kind of interchangeably. They have the benefit of they don't have the same kind of side effects for the topical steroids as far as the local thinning of the skin, lightening of the skin, or anything like that. The most common adverse effect is that they burn. And so a lot of patients will complain of this, especially if it's used on warm or kind of on open skin, or if it's used whenever they're first trying to heal the skin. And so there's some mitigation things that we can always talk about. I always talk to my patients how to not use it directly on when you come out of the bath, because this is one that can, if the skin is more supple, if the skin is more warm, it actually can cause you more problems. If you can use it, if you use it continuously, if you use it kind of frequently, the stinging sensation does go down, and it can be mitigated with the stinging can be mitigated with chilling the product just for a little bit before you actually use it. It does have a black box warning. The same medications, pimecrolimus, tacrolimus, the calcineurin inhibitors, in oral forms in higher doses, were used as immunosuppressants, and so you're using it as a topical form. And so there is a risk of cancer. And big meta-analysis, even in kids down to 2 years of age, there's not risk for certain diseases. There's a slight increased risk compared to the general population for lymphoma that we're still trying to figure out, but it doesn't look like it's a substantially bigger risk, but the black box warning does sit there. And so we do always have to talk about that. It is safe. They are effective, even for long-term use though. The other topical medicine is crisaborole, which is a topical phosphodiesterase 4 inhibitor. This one is approved down to 3 years of age. So for our individuals who are afraid of the topical steroid utilization, we can use it. It's probably better for more mild atopic dermatitis as a steroid-sparing agent, entirely because it's not as strong as either the calcineurins or the topical steroids. And this one really stings. So the topical calcineurins, they kind of sting. Crisaborole can really sting. And that is the most common reason people stop using crisaborole. That one you can mitigate a little bit by continued use or by using it cool, but that is the most common reason that it was discontinued on most of my patients. The new players in the box. This is the first of the topical, or the first of the Janus kinase inhibitors. So there's going to be some oral medications that we'll talk about in a second, but we'll talk about the JAK inhibitors kind of throughout. So the topical JAK inhibitors, the first one of its kind came out in 2021 and is called ruxolitinib. It is a cream. It is approved for 12 years and above. It is being studied in younger individuals, and it looks like it has similar effectiveness. And actually, some of the limitations are a little bit less in younger kids, but we're still trying to figure that one out. The risk is that it gets systemically absorbed. So anytime you put something on the skin, there is some level of absorption through the skin, which is one of the reasons why we are always more cautious with our ultra potent topical steroids. The topical JAK inhibitors do have a risk with absorption as well. And so we try not to have continuous use for ruxolitinib past four weeks. Try to use it on less than 20% of our body surface area. And so we have to limit how much we're actually using as far as everything goes. It has a similar efficacy. So it kind of compares to those mid-potency topical steroids. It really, really helps with itch. And so we'll talk about the JAK inhibitors, kind of where they actually function again in a second. But the topical JAK inhibitor, ruxolitinib, really helps when you actually look at the studies for itch. And so pruritus is itch compared to the topical corticosteroids. And it has a steroid-sparing agent. So it is a great option. It is expensive right now. And then I'll go into the class-specific warning, but there is a class-specific warning for all JAK inhibitors for risk of cancer, major cardiovascular events, thromboembolic events, and infection. So that's kind of our topical medicines. We're going to dive into the systemic therapies that I wanted to make sure we talked about, because that's the goal of this talk. But you can't talk about atopic dermatitis without addressing that as well. The big question that I ask myself all the time, and most providers should be asking themselves, most patients should be asking themselves, is when is topical not enough? When do I need to kind of treat this whole disease? Because we talked about atopic dermatitis, that it's a whole skin issue. It's not just one little spot of our skin. It's really an entire skin barrier issue. So these are guidelines that have kind of come out and kind of been published that say, hey, this is when we should be considering it. So if it's persistent diffuse, or if it's locally severe with significant impact on quality of life, despite adequate trial of high quality topical therapies. And we as providers need to assess whether our patients are actually using what we think they are. So not just them saying, yes, we are using it, but making sure that they're filling it from their pharmacy. They're not having adverse effect that is limiting their use. And we are trying to help them find a way to not have a limitation to their use in any way that we can. and that we've ruled out other disease alternatives as far as the differential for eczema that we can actually approach their skin so that we actually can make sure that we are treating the right disease. And that's one thing that we are trying to always do a better job. I'm not going to have enough time in 45 minutes, 50 minutes to an hour to talk about the ongoing investigation into biomarkers so that we can actually better personalize our medical decisions for the ideal therapy, but that is something that is in the works. And as we learn that this is a disease state that affects each individual slightly different, is that I think that if you asked us in 5 years, 10 years, 20 years down the road, we may have a different answer as far as what is the best medicine to use. And so when I talk about the systemic therapies, I always explain that there's only a couple of head-to-head comparisons. There's not a ton of studies that say, hey, this drug studied against drug A, against drug B, against drug C, and drug A is the greatest thing ever. It's really important for us to compare the studies that they did and compare their efficacy. And in the few studies that we get, we can actually try to talk through them. And so when we talk about the systemic therapies, there's a couple of things that we always talk about, and that's the important terminology to use, which is how do they work? And so we have standardized scoring systems. And so you'll hear us use the term SCORAD, which is a scoring for atopic dermatitis, the EASY, which is the eczema area and severity index, which is probably utilized the most often, or the validated investigator global assessment. Those both are kind of starting from how much body surface area, how inflamed is it in that specific area, what does it kind of look. The goals for all of these is try to obviously see those numbers as close to zero as possible. And we look at how much they change from whenever I start a therapy or where they're at before I start therapy to whenever I have initiated a therapy, and how does that change? And so you'll hear for EASY, you'll hear us talk about it in terms of EASY 75. That means that, so it'll say EASY and then it'll say a number. And so that number is the percentage decrease. So if it's EASY 50, that's a 50% in their EASY score. EASY 75 is a 75% reduction in their EASY. So whenever I talk in a second about those different scores, we have to understand what those are. And the last one that I would talk about is the peak pruritus, or the worst pruritus numerical rating scale, which is really a great measure of how itchy the skin is for our patients so that we can actually approach them. So I'm going to start with biologics, and then I'm going to talk about the JAK inhibitors, and then I'm going to talk about some kind of oncoming medications that we're actually looking at constantly down the pipeline. So once again, I'm going to put the slide up again because I know you guys saw it. I know everyone paid close attention to it while I was talking through it, but I'm going to draw our attention to the blue and white bubbles that are in there. So when we actually look at the inflammation that kind of starts it from the skin barrier kind of coming down, you'll see those alarmins. Those are TSLP, IL-25, IL-33. Those are signaling down to our immune system, to our helper T cells that are skewed towards allergy, called our Th2 cells. Those Th2 cells are then in our innate lymphoid cells, our ILC2. So those 2 cells are going to make certain cytokines or certain signals that are going to drive inflammation, whether that is IL-31, which is itch, IL-4/13, which skews our allergy antibody producing cells, or our B cells, to make IgE, or to recruitment of our end effector cells like our eosinophils to actually cause us problems. And so when we actually talk about the medications that we use, we target it to different pathways to calm down. And in the skin, we really pay a lot of attention to IL-4/13, and then for itch symptoms, we look at IL-31. So the first of its kind, the granddaddy of them all, shouldn't call it the granddaddy, I apologize for that. The medicine that's been approved the longest is a medicine called dupilumab. It is an interleukin-4 receptor alpha monoclonal antibody. It was first approved in 2017, and now it has been subsequently kind of progressively stepped down in age, and it is approved 6 months of life and above. It is an injection. So it is a subcutaneous injection that is done at home with a loading dose, usually twice the kind of the maintenance dose. And it's dose based off of age and weight. And so you use either 200 milligrams or 300 milligrams every 2 to 4 weeks after that loading dose. And it is something that is done at home. And so it gives the flexibility of being done at home. So a lot of our biologics for other diseases, we actually have to do it in the office. This one can be done at home. And it does treat multiple diseases. So it's not just approved for atopic dermatitis, it's approved for severe asthma, for chronic rhinosinusitis, nasal polyposis, and for eosinophilic esophagitis. And the indications are starting to grow and more as far as dupilumab. And so that is one that has been probably widely talked about for a while. And that is the kind of the gold standard for the longest time. And so when you actually look at it, I'm going to kind of focus on each study and then the long-term study. So the left study is the initial adult phase 3 trial The middle is the 6 to 11-year-old, and then the right is the 6-month and above study, and then the bottom right is the 4-year long-term study. So all of them had a big improvement in atopic dermatitis. So in adults, by 16 weeks in their solo 1 and 2 study, they had a 75% reduction in their EASI score, and 40% had an IGA, or kind of a graded assessment that their skin was clear or almost clear. And it was studied both as its own therapy, so not having them to use any kind of topical steroids, any kind of topical therapies whatsoever, as well as an adjunct, or kind of an add-on. And that's how it was actually approved. And so it was approved as an add-on therapy to people who have failed topical therapies. And then when you look at it at each age, it looks like it has benefit for everybody. So in the adults, it had, in just 16 weeks, 50% of patients reached an EASI 75 of 50% within 16 weeks. And then in the younger kids, in the 6 to 11 years old, 80% of patients reached an EASI 75 by the end of their 16-week treatment. And then 50% of kids that were younger at different doses. So they looked at different doses weekly, every 2 weeks, every 4 weeks for younger kids. And they kind of tried to find what was the right dose and then what was the most effective dose. And so when you actually look at it, it works across all age ranges. It's pretty similar as far as the reduction, but in general, it's a very effective medicine. And it does start working pretty quickly within 4 months. And then the long-term study, kind of that lower right side, shows that it still keeps working. So after we kind of get it, you still see that they progressively get better. So the top bar, is the EASI 75. The red bottom things are EASI 90. And the green is EASI 100, so 100% clearance. And out to 4 years, they have an EASI 100, so completely clear skin in 75% of patients, which is remarkable as far as the disease state. And so it really has been a game changer for our management for atopic dermatitis. So when we talk about dupilumab, the ideal medicine or the ideal patient to use dupilumab in, one that has other comorbidities, if they have bad asthma, if they have chronic rhinosinusitis, if they have eosinophilic esophagitis. And so it really does kind of treat multiple disease states, but it can really help with all of them. And trying to figure out which drug can treat multiple medicines or multiple diseases is really a great option, because it does kind of hit across the spectrum, and it really has a benefit to patients where I'm treating with one medicine, treat multiple things. They do have to have at-home administration, so it really does have to have the capability. And then this is the one that is approved the youngest, so that goes down to 6 months of life. There are still some things that we don't know about dupilumab. We are still learning. As a pediatrician by background, I'm always concerned about anytime you go down to 6 months of life is vaccine data, is that we don't know how it interacts with live vaccines. That is actually considered a contraindication right now. We're looking at it. Adult vaccines, so there are a couple of studies that have looked at how people have responded in other countries to yellow fever, and they're looking like it's not changed, but it's something that we still don't have a great answer on. And so that's something that we don't fully know yet. And then it does have a side effect. I didn't actually talk about the side effect. The most common adverse event is injection site irritation. So where they're actually doing the injection site is painful. The ocular side effect is the most specific to atopic dermatitis. It doesn't really occur in other disease states, but it really does occur in atopic dermatitis, where they get a really bad non-infectious inflammatory conjunctivitis, where they actually can get, starts out as dry eyes. For some people, that's all it does. And for some people, it can actually be, exudative, or kind of can be, pus, or kind of can get matted, or can actually get issues. And they have to be involved with our colleagues with ophthalmology. And sometimes we actually have to just treat it with eye drops, just kind of treating it to moisten, lubricate the eyes. But some patients actually have to go on topical steroids or topical immunosuppressants to kind of help in that. Some patients, we have to stop them in treating and from using dupilumab, and some patients we're able to keep treating through. And so it is a varied thing that requires kind of a whole team to come together and treat. And so it's an adverse effect where if I have a patient, if they have really bad conjunctivitis symptoms, allergic rhinoconjunctivitis symptoms at baseline, it's probably not the right medicine for them at that time, but we have to find that right balance. The next one that kind of came out is tralokinumab. It is another, so it's in that same pathway. So dupilumab blocks IL-4/13, kind of both cytokines as they converge at the actual receptor. Tralokinumab binds to IL-13, the cytokine itself. So it's slightly different location, but similar pathway. It was approved for adults in 2021, at the end of 2021. And it is still just approved 18 years in age. It is only approved for atopic dermatitis. It doesn't have any other indications. It's being studied in younger kids, and I think that it will likely have that. But the benefit for tralokinumab is that while it has the same dosing structures at the onset, you have some capabilities to actually space it out. And so whereas dupilumab is every 2 weeks kind of consistently, the tralokinumab is done a little bit different, where after 16 weeks, you can actually space it out. So their studies were called the extra studies or the extend studies. The top two are the extra studies. The bottom one is called the extend studies. And so at 16 weeks, which is usually where we kind of target, like, is the therapy working, is it not? There is a great reduction in our patients with on tralokinumab every 2 weeks, and at that 16 mark, they're actually doing really well. You can consider spacing out. So that's what they did in the next step down below, and I'll talk about that one in a second. But they really did kind of show that with topical steroids or without topical steroids, that there was a benefit, and that in their 2-year trials, in their extend trial, they had a sustained benefit after they were able to space it out from every 2 weeks to every 4 weeks. And then they even went a step further, and when they stopped the medicine, some patients that they stopped tralokinumab, they actually had sustained improvement multiple months after stopping a medicine. So it has potential for disease modification that actually can then mean the patients are on less medicine. So it's an interesting medication that kind of bears some promise. So tralokinumab, the ideal patient, at least right now, it's being studied in younger, but at least right now, is adult patients with severe atopic dermatitis failing topical therapy, because it was approved as an adjunct or an add therapy, that prefer or are comfortable with injections, that are comfortable doing those injections at home, that have the capability after 16 weeks to be able to space it out, to actually continue it on. So it's a really interesting promise. The adverse effect is the same for conjunctivitis for dupilumab versus tralokinumab, and it's about the similar rates. And so if somebody has really bad conjunctivitis, they're slightly lower. There are some of the patients that were in the clinical trials that were previously on dupilumab, and they were able to go to tralokinumab, and they had less symptoms, or actually had some sustained benefit for their skin. And so there is some nuances that we still are learning on which patient is the right one to put on each of them. And we still are learning kind of long-term data. It was only approved in 2021, and so they're publishing kind of long-term data consistently. And still the same question on live vaccines is unknown. There's not as many live vaccines in adults as there are in kids. And so that'll be an interesting question when they kind of start going younger. And so the main course of this lecture is the JAK inhibitors. I know that's what it was touted as far as a webinar goes. And so reminder again, when we talk about our cytokines sit as a ball into a glove, and then it kind of signals as a domino downstream into the actual cell to cause production from our nucleus to actually make proteins. That signaling that starts everything at the base of that receptor are the Janus kinase signals. And so those are different for each cytokine in different receptors, and they're different for each disease state. So our infectious cytokines that we call Th1 is kind of more of a bacterial infection signaling. Those ones do use the same kind of JAK inhibitor, or the same kind of JAK signaling, but they do combine slightly different to make with different stats, or kind of like the downstream signal transducers. And so we have to kind of combine which one of these is going to be the right one as far as what we are going to inhibit. And so when we actually look at the JAK inhibitors, we have to know which JAK do they inhibit to know which disease state it will be good for, or which patient it will actually be good for. So I'm going to talk about the elephant in the room. I think this is an important thing for all doctors to talk about. I know that anytime that you see a pharmaceutical talk, they have the litany of side effects. They talk way too fast for any of us to actually understand, but there is a class or a black box warning for all of the JAK inhibitors. And so I want to address the elephant in the room. And so for a class warning, they carry a risk of cardiovascular events, of cancer, thromboembolism, serious infections, and herpes zoster. And all of that was, not all of that, most of it was based off of long-term studies in patients with rheumatoid arthritis that were on tofacitinib, which is a pan-JAK, or kind of inhibits every single Janus kinase signal in patients with rheumatoid arthritis. And it compared them to patients that were on an anti-TNF medicine. And so when you compare them, it's in a different disease state. So it's important for us to know it is in a a different inhibitor. And so we really are extrapolating it to an entire class of medicines based off of one medicine that has many different, I don't want to say, it targets many different pathways. And so we have to know if we're comparing apples to apples or apples to oranges. But in the long-term data for tofacitinib, which is a 3.5-year study that kind of compared the rates for tofacitinib to the anti-TNF medicines in patients with rheumatoid arthritis, there was a higher rate of major cardiovascular events, there was a higher rate of cancer, and there was a higher rate of venous thromboembolism and serious infections and herpes zoster. Not going to deny it, it was there. Most of those were likely related to some risk factors, and we'll kind of talk about that. And so whenever we actually talk about our JAK inhibitors, whether that's the topical or the oral, we have to know what their risk factors are. And so it does seem like it tracks along with other risk factors for major cardiovascular events or for cancers or for venous thromboembolisms, which is age over 50 and smoking history, hypertension, hyperlipidemia, family history of coronary artery disease, or medications that can increase the risk. And so it's important for us to kind of know that. And then the way that the studies were drawn or designed actually will affect how we actually need to interpret it, because you can do a selective bias. And so that's actually going to be important when we interpret their data, is that we need to know what their bias was, because some studies were designed differently and kind of and kind of removed that sampling so that you don't have that risk. And so topical ruxolitinib, in their longer term studies, so not in their short-term studies, in their longer term studies, did have 1 myocardial infarction, 2 cerebrovascular accidents, and 3 thromboembolic events that weren't related to the medicine. So it was earlier in the treatment course. They did have risk factors, but they were there, and so we can't deny it. Abrocitinib hasn't had one that I'm aware of. Whenever I was looking through the literature previously, and I kind of re-looked over the last couple of days to make sure I wasn't missing anything. But they haven't had one yet, and I'll talk about why I think that actually is the case. And then upadacitinib did have some. They had some major adverse cardiovascular events and venous thromboembolism. So they have been linked to them in different drugs. And so the recommendation is kind of just talk about it to kind of make sure that we're finding the right patient. And then there's a risk for reactivation of herpes zoster. So if you have a risk factor for herpes zoster, to make sure that we vaccinate before. And it does require labs testing. So you can't just start these medicines without knowing what we're doing. We have to know what we're getting to. Before we start this therapy, we have to screen our patients. We have to do a test to make sure they don't have tuberculosis. We have to make sure that they don't have kind of smoldering underlying hepatitis B or hepatitis C, which is going to be different in kids versus in adults, but it is an important thing for us to know. And we have to know what their baseline blood counts are and what their baseline liver function is. And in females, are they pregnant? Because we don't have pregnancy data for them. And so there are different cutoffs as far as what we would avoid, because it can cause some cytopenias or some low blood counts. It can cause some changes in platelets or kind of the production for the bone marrow. And so kind of thinking through what's the best one. And then we actually have to follow people on it. And so right now, the recommendation is after you start a medicine, 4 weeks after you start it, you repeat your CBC, or if you increase the dose, you repeat it. And then you check a lipid panel 4 weeks for abrocitinib and 12 weeks for upadacitinib. So let's actually talk about all of them. And so let's kind of go through each of them individually and let's talk about them. And so we can kind of see which one it is better. So abrocitinib was approved in adults 18 and above in 2022, and then in adolescents 12 and above in 2023. And so it is currently FDA approved inside the United States for 12 years and older. It's only approved for atopic dermatitis, so it doesn't have another indication. It is a selective JAK1 inhibitor, so it only targets that Janus kinase 1 pathway. It has 3 different strengths. So it has 50 milligrams, 100 milligrams, and 200 milligrams. They recommend they start it at 100 milligrams. You can take it up unless you are on a medication or that can inhibit the metabolism, or you have renal impairment. So that's why we have to have labs before we start it to kind of figure out what is the right medicine for it. And certain medicines, like antifungal medicines, proton pump inhibitors, or some of your antidepressants, like your serotonin selective reuptake inhibitors and your antivirals, can increase the drug level for this. And so you have to be cautious on the patients. And then you do, once again, I'm going to say this again, and I think that we need to talk about is there need to be monitors. You can't just start this medicine and walk away. You have to start a medicine and kind of follow people. And so once again, you do have to check labs 4 weeks after you initiate it. So the abrocitinib studies were called the JADE trials or the JADE mono trials. These medicines worked. So abrocitinib was a little bit more choosy in the patients they put on it. So they when you actually look at their demographics, their patients were in general 23 to 45 years old. So really your younger population, your healthier population, just really whenever we kind of talk about those risk factors, they have not a self-selection, but they were allowed to have any comers, but that enabled that they're going to be the most clinically, their trials were most comparable to the clinical usage for these medicines. And so it kind of gave them that facilitated aspect. And so they work, man, oh man, do they work, and they work quick. There is a dose effect. So the 200 milligram is stronger, but it has more side effects. And the 100 milligram works and it sustains its effectiveness. And so when you actually look at it, when these medicines first got approved, we stopped talking about the EASI 75, so the 75% reduction in the EASI scores, and we started talking about EASI 90s, EASI 100s, which for somebody who's taking care of atopic dermatitis with a lot of the topical medicines, only about 30% of patients will have an EASI 75 on topical medicines. So these medicines going to 90% reduction, 100% reduction in eczema was just astounding to me. And so when you actually look at the studies, almost 8 to 10% of patients by 12 weeks after starting these medicines will have completely clear skin. And almost a third will have no itch whatsoever within the first 1 to 2 weeks of taking these medicines. And so if itch is their major symptom, really it's one of the best medicines to do it, because it really does target the pathway for itch really well, because it actually targets some of the cytokines for itch directly at the neurons. And so it is a really, really strong, potent medicine. The most common adverse effects were upper respiratory symptoms. So congestion, kind of some sore throats, some abdominal pains and headaches, some acne, and some cytopenia. Nausea and acne were higher at the higher doses, and that kind of did get better with the lower doses. And so you could always kind of drop them down if they were having side effects. Obviously the most common severe that we're always going to talk about is our risk for infections. And this was done during the pandemic. And so there was, how is this going to affect, is it going to be truly immunosuppressing? It doesn't look like it's the same kind of immunosuppressant or broad spectrum immunosuppressant, but there is increased risk for infections and herpes. And it does carry the black box warning, though there were none reported in the phase 3 or in the extension, but their population was younger. Their population was 23 to 45 whenever you actually look at their demographics. They were healthier. They didn't really have risk factors. And so they're probably the most comparable to what we're talking about using from a clinical standpoint, right, of like real world trials and saying, hey, this is what it compares to in the real world. If I'm choosing a drug for this population, the younger, the healthier, it may be the most comparable that I can actually say, hey, this is how it would actually work. And so it is approved, FDA approved, 12 years and older inside the United States. It is an oral medicine. So these are oral JAK kinase inhibitors. If itch is their major symptom, it works fast. And if they don't have risk factors, so you have to take a history, you have to kind of talk through it. It is contraindicated in pregnancy. We don't know about breastfeeding, so that one we're still trying to figure out, and in avoid live vaccines. And so I put in the little thing at the bottom of here, generalizability concerns, because a lot of trials, they tend to have they tend to kind of skew towards different populations, and they tend to have not always the most diverse. And so it's important to kind of know when you're actually comparing everything for all of our patients. So I will try to go quickly because I know it's in the last little bit, and I apologize that I'm going to talk a little bit faster. Upadacitinib is the other oral JAK kinase inhibitor. This one is approved 12 years and older for atopic dermatitis. It's also being studied younger. This one does have additional indications for psoriatic arthritis, ulcerative colitis, Crohn's disease, rheumatoid arthritis, ankylosing spondylitis. And so a lot of your autoimmune conditions, it is higher affinity, but it is not selective. So abrocitinib was selective. It really binds with the highest affinity at the JAK1 signal mechanism. This is higher. It has major impacts on JAK1, but it has some kind of minor on some of the other ones. So it does not get to claim the selective aspect. The dose comes in 2 different doses, so 15 and 30 milligrams. We always recommend starting at the lower dose, and we can always increase if they're over 40 kilograms or 88 pounds, and they are less than 65 years of age. You do have to do drug monitoring prior to, so you have to get a blood count, you have to get liver electrolytes, you have to get renal function, you have to get tuberculosis check, hepatitis B, hepatitis C, pregnancy test, and you have to repeat your labs 4 weeks for a CBC and 12 weeks for a lipid panel after initiation, and if you have to increase the dose. And so when you actually look at their trials were called the Measure Up trials. They work quickly. So within 4 weeks, 2/3 of patients or 3/4 of patients at the higher dose had dose response to reduction in their EASI-75 score within 4 weeks. And there was dose response, so 30 milligrams was higher, the 15 milligrams was lower, but they work. And the itch improved within the first week. And so it really, really kind of shows a lot of promise. And then they studied it out to 52 weeks, and they showed that 58-60% of patients on the lower dose and 72% of patients at the higher dose sustained that benefit. And then there was 40-60% of patients reached an EASI 90, and then 10% to 24% for the 30 milligram reached an EASI 100 with sustained benefit out to a year with the same kind of benefit in their itch. I meant to say, so the middle panel is the 16-week, the right panel is their extension. So from a safety standpoint, upadacitinib has similar adverse effects. It does have an acne risk factor. It does have nasopharyngitis or kind of upper respiratory tract symptoms. Has some nausea, some headaches, some creatine phosphokinase elevation. And so what that means for the muscles is something we're trying to figure out. And does have the most common serious adverse events were herpes infections, either herpes zoster or herpes labialis. And then there's risk factor for serious infections. They did take all comers. They did take patients that were on OCPs, and so they actually had a little bit of a kind of a broader spectrum. And they did allow patients that had a history of major adverse cardiovascular events and venous thromboembolism. And they did have those that occurred. And so they had 2 patients at the lower dose, 1 patient at the higher dose that had cardiovascular event. And they had 2 venous thromboembolism. And they had nine total cancers, I believe, if I remember counting correctly. There was 1 death in an older population. So it was a guy that was over the age of 65. It was complicated because he had a COVID infection, he had comorbid diabetes, he had obesity, he had hypertension, hyperlipidemia, hypercholesterolemia. And so there was some risk factors there, but he did die while he was on the drug. And so I think that it's important for us to talk about this and try to figure out which is the right population. So they've gone back and they've looked at their pooled analysis for atopic dermatitis for all of their indications: atopic dermatitis, rheumatoid arthritis, ulcerative colitis, and they have kind of studied it out for patient years and what kind of those risk factors are. And it looks like the major adverse cardiovascular events and the venous thromboembolisms are less than 0.1 events per 100 patient years. And the malignancy rates are kind of low as well. And then the herpes zoster rates are a little bit higher than what you expect, but they're there. And so it's a medicine that it does quiet down some aspects of the immune system, so it poses risks, and we have to think about it. So upadacitinib is an oral preparation as well as abrocitinib. It is approved 12 years and older. If your patient is, or if you as a patient have itch as your major symptom, and you really are like, I need something that works now, it's an interesting option. And so you have to limit their risk factors. And so you have to kind of talk through who is the right patient to put it on and who to actually use it on. And so it has very similar. And so I would love to say that I have a ton of head-to-head data that I can be like, hey, let's compare all of these together and say who works best. Each of the individual oral JAK inhibitors did compare themselves to dupilumab, since it was the longest medication that was on the market and kind of like the cream of the crop at the time. And so they both compared themselves. And abrocitinib is the one on the bottom. Upadacitinib is the one on the top. And so we'll talk about upadacitinib first. So they both did only a 16-week study. So they only did it over a 4-month period of time. It looks like both of them actually worked faster. So they both worked quicker. They had a shorter time to effect, and they had an improvement in their EASI score quicker than dupilumab. But dupilumab would catch up, and so with time, dupilumab caught up with similar effectiveness. The upadacitinib 30 milligrams, the higher dose, did remain better than dupilumab for EASI 90 and EASI 100 and pruritus, but for abrocitinib, dupilumab completely caught up. And so it's one of those things is that it's not like, you're getting a suboptimal medication, but it does kind of make us ask the question, is short-term goals versus long-term treatment, which is going to be a better option. And so we've had a lot of meta-analysis that have tried to look at it. The first one that was published was in 2020. That was before abrocitinib and upadacitinib were FDA approved, and there was only trial data for tralokinumab. And it showed that dupilumab was the most effective systemic therapy for atopic dermatitis. And then a year ago, they went back and they reanalyzed it and they said, look, you got to prioritize safety or effectiveness. And you got to kind of choose which one is your priority. And so they showed that the most effective is going to be upadacitinib, followed by, at the higher dose, followed by abrocitinib and dupilumab, which are kind of even, which is kind of even with upadacitinib at the lower dose. And then that was better than abrocitinib, and tralokinumab was kind of right around there. And so the most effective kind of descended progressively, whereas the highest safety was dupilumab, barely beating out tralokinumab. Those two are really close as far as safety. And then upadacitinib, abrocitinib are kind of on the right-hand side. So I will take questions at the end. I apologize. I'm going to try to crank through some more just so I don't keep you guys over the time frame. But the research pipeline for atopic dermatitis is really exciting. So whenever I was looking at it a month ago, and then whenever I was looking at it yesterday, there's over 200 currently active or currently recruiting phase 1 through phase 4 trials for atopic dermatitis. And of those, about 30 of them have started up in the last month. And so it is really a promising time to be taking care of patients with atopic dermatitis. It really is a disease state that we are trying our best to get better therapies, better options for our patients. And so when we talk about the skin, these are all the medicines that have been tried or are being tried in eczema. And so they actually are looking in atopic dermatitis at different pathways, whether that's and I'll kind of talk about the big players and kind of which ones I think are the closest, if I had to guess. But they're looking at from the skin side out, and they're kind of looking all the way down at itch. They're looking at which ones affect B cells, which one affect helper T cells, which one will actually have implications on the stratum corneum, which ones will actually help with the microbiome, which ones will actually help in each individual case. And so the first ones are kind of the starting on the outside layer of the skin, kind of coming inside, which are the barrier therapies or the alarmins. So we've looked at anti-TSLPs, anti-IL-25 and IL-33, which are our classic alarmins that we think about. None of those reached clinical significance in trials, and so those kind of have been pulled out back, even though they're working in other disease states, and the anti-TSLP has been approved for asthma. But one of the big ones that has been looked at is the itch signaling. So it's IL-31. It's different. So there's a reason that we don't use antihistamines as much for atopic dermatitis, because the itch in atopic dermatitis is driven through the nerves. It's driven through a cytokine that signals to the nerves to call attention to that spot, and it's called IL-31. And that IL-31 is signals through Janus kinase, and so that's why the Janus kinase can help with Janus kinase 1 can actually help with itch-related symptoms. So there's a monoclonal antibody that's looking at IL-31. It's called nemolizumab. They just, as of a week ago, or sorry, 6 days ago, put out their phase 3 trials called Arcadia, which is Arcadia 1 and 2 is for atopic dermatitis, Olympia is for prurigo nodularis. And these ones, they don't look like they're as effective for the EZ, but they work really well for the itch. And so when your symptoms are itch driven and you can break that itch scratch cycle, establish good topical therapies, it looks like it can actually help kind of restore that skin barrier for patients that are responsive to topical steroids, but itch just keeps on kind of tripping them up. And so that one is something that is still in the pipeline. I think that one is an interesting player to watch, either as monotherapy or as an adjunct kind of coming down the line. The one that I thought was closest, and I would have said a month ago that I thought was the closest to coming out, was lebrikizumab. Lebrikizumab, similar to tralokinumab, is an IL-13 monoclonal antibody. It was recently rejected for FDA approval due to manufacturing issues. And so it works, and even the FDA said, hey, look, the medicine works. The phase 2 and 3 data shows that it works. It works out to 15 weeks. It has a lot of a benefit, but there was some trip ups in the manufacturing processes. And so that one needs to reapply or kind of needs to fix some things before it's actually able to get approved in atopic dermatitis. They're working on some biosimilars to dupilumab. And so those are AK120 and CBP201, I think is what the name is. Oh yeah, that's right there. Rademikibart. And so those ones are being studied at 2 and 4 weeks to try to figure out which one is best. And so those are still in the kind of the early side, phase 1 side. And so those ones likely will have promise because that same pathway has been studied and it shows that it has worked. OX40, which is the communication between the innate cells, the dendritic cells that are in skin that signal to recruit the T cells, once they actually come back to the skin and home to the skin, it kind of activates those T cells and says, yep, you're supposed to be here, attack the skin, start making cytokines. There's kind of a lock and a key mechanism, which is the OX40 pathway that kind of signals, yep, allergy, Th2 cells, you're supposed to be here. And we're looking at different medicines that kind of target that. So there's rocatinlimab and amlitelimab. Are kind of two ones that kind of block one versus side. So OX40 ligand is on the dendritic cells, or kind of the antigen presentation cells, and then OX40 is on the helper T cells, the allergy cells that kind of push us in that direction. And so they're both being looked at in phase 2 trials. The reason I brought these ones up is that they are kind of interesting because when you dose them, they show benefit while you're on them, and they're monthly, so they're every 4 weeks. And then if you stop them, you have continued benefit for out to 6 months. And so you treat them 3 months, boom, they're good for a total of 9 months. And so, which is kind of interesting. So it kind of tells you that if you can kind of hit reset and you kind of break that cycle, and then you establish care, you can actually help guide our patients a little bit better. And so there is 2 other JAK inhibitors that are being looked at. One is a pan-JAK inhibitor, that is a topical preparation for a pan-JAK inhibitor that is approved outside the United States, that is being looked at inside the United States. It's on par with ruxolitinib as far as the topical JAK inhibitors. It's called delgocitinib. It is more broad spectrum based instead of being a little bit more targeted, more specific. It doesn't seem to have the systemic absorption risk, but that is one that is approved outside the United States. It's going to eventually be kind of talked about in here. And then the other JAK inhibitors is JAK1/2. So abrocitinib, upadacitinib, mainly JAK1. Baricitinib is JAK1/2. JAK1/2 can be involved in other inflammatory conditions and infections, so it kind of makes us always kind of worried. That one is approved for atopic dermatitis in Europe and Japan, and is approved for rheumatoid arthritis in the United States. It's not yet approved for atopic dermatitis. They have 2 different doses, and there is a dose response as far as the higher dose. 4 milligrams does seem to be more effective. Their studies were called the Breeze AD trials, and they showed moderate effectiveness, but they also had like headaches and upper respiratory tract infections. And I apologize, that was like a whirlwind talk for an hour, but hopefully I didn't bore you guys too much. The key takeaways for atopic dermatitis, it's super complex. It is something that we need more people that are kind of focused on how we can actually take care of the skin, what we can actually do, what are some real world data as far as what the best option, and then having conversations with providers as far as what is the best thing for that specific patient they're taking care of, and kind of getting everyone's preference. Is it speed? Is it safety? Is it oral preparation? Is it injectable? Kind of what do we actually want to think about? And then long-term data. We have, dupilumab. We have, I think that they just put out, I think I saw 7-year data. And so I know they published 4, and I think they're pushing up to 7 years for other disease states. And so trying to make sure that we find the right medicine for each patient, and that we follow that over time, because it's all good to help something now, but we need to know what it is long term. And then the future's incredibly bright. So for the first time in a long time, for a disease that only we've had topical medicines that we can put on people, this is a disease that we finally can actually help with. So that's all of my citations, which is a whole lot. I'm going to take a time to answer any questions.
Wow, Dr. Dunn, thank you so much for that incredibly detailed look at all the treatments that are on the radar now for atopic dermatitis and that are coming online. I was involved in the Atopic Dermatitis in America study back in 2017. This was before dupilumab, and the picture was rather bleak and hopeless for people suffering from moderate to severe atopic dermatitis. And now, like you said, the future is so bright. There are now solutions to allow these folks to not suffer. And the children were just having such a hard time. It was just heartbreaking. So it's just a wonderful, bright, optimistic kind of story that you're painting here. There's so many options, and hopefully atopic dermatitis won't be a thing to worry about because of that. So I know that we're really coming up on 5:30. That went really quickly. Just want to give everybody a quick information. Our next webinar in November is going to be Holidays with Food Allergies with Dr. Mike Pistiner on November 14th. And then we're going to be doing asthma and anaphylaxis with Dr. Ann Hoyt on November 29th. So you'll be getting updates on those and how to register shortly. And so also look for a follow-up email in a few days with additional links to regarding information about atopic dermatitis that you will find helpful. We have a lot of educational resources about it. So it is 5:30, and I know some of you will have to drop off, but Dr. Dunn, would you stay another 5 minutes or so to answer a few questions?
Of course.
Okay, anybody that has to leave, thank you very much for being here, and then we'll go ahead and answer some questions. So the first one is dupilumab a continuous therapy? What's the duration? What does that look like?
So I think that's one thing that we are actively trying to figure out. And so we don't know. So we know from preliminary data on some of the long term that there seems like there's a couple of different trajectories, and we don't know how to predict which people go into which trajectory. Some people it hits reset and they're able to come off it and they don't have any problems. Some patients it comes back more mild, and some patients it comes back just as severe. And so it can be used as a continuous therapy. It has been studied as a continuous therapy. In the phase 3 trial or the phase 2 trials, they actually looked at the frequency, and they actually showed that weekly was more effective than every 2 weeks in adults. That had more side effects. That's why they went with every 2 weeks in adults. But no one has kind of been looking at what is the ideal point to stop any of these medicines, other than kind of the couple that I told you about, the OX40 pathways and the tralokinumab, where they actually are spacing out the dose. And so that is probably the number one question that we are all asking ourselves from an allergy standpoint, is we're trying to figure out when can we actually stop these.
Okay, great. So both the JAK inhibitors and biologics, they're all going to be or are prescription only. Is that correct?
Right now they are, yes, ma'am.
Okay. Okay, let me see what other questions I have. Just bear with me for so much. Well, I think one of the things that I learned was that there's different immune pathways for acute versus chronic atopic dermatitis. So thank you for teaching me about that. And that it's all modulated by different immune cytokines. And so that was pretty interesting. So when you're dealing with skin of color, because you brought up that really interesting slide, does that sort of also guide your treatment recommendations and your shared decision-making conversations?
So the easy answer is right now, we're a little bit more blunt in the way that we kind of approach it. I think that a lot of these pathways can be inhibited by these drugs can inhibit multiple of the pathways, and it can actually affect it. I think that once we kind of have a better way of identifying which biomarkers are higher at the onset, because even though we can make a generalized statement about, okay, so this is how skin of color behaves, each individual is so personalized. And so when we actually talk about the melting pot that is the United States, where there is some level of multi-ethnicities in each individual, sometimes that can actually skew a lot of the data. And so I think that the easy answer is it doesn't change what I'm doing right now. Some of it is limited by what I can get approved. What is the age of the individual? And also what pathway I think is probably driving them, and what comorbidities they have.
Okay. Regarding dupilumab, I mean, I know that conjunctivitis is one of those things that can happen, but how often does it happen that somebody is so refractory with conjunctivitis that you have to stop dupilumab?
It's pretty rare. And so when you talk about it, there's a couple of strategies that you can try to do. And it does work better when you're working in conjunction with an ophthalmologist, as far as how to actually have medicines that calm down irritation in the eyes, but also can keep you kind of on the medicine. Usually you do notice that it's more often right after you get the medicine. So sometimes spacing out the dose, sometimes taking eye drops around the time that you're going to do the dose. There are some patients that I haven't been able to keep it on it, but those are a smaller number than will have symptoms. I think that the studies will say up to 10% of patients with atopic dermatitis on dupilumab will have conjunctival symptoms, but not all of those will actually have to discontinue. Some of it self-resolves, so you don't even have to do anything. You just kind of treat through.
Okay. Great. So, I mean, I'm a mom, so, when I think of a JAK, it's a pill versus injectable, I'm thinking, oh, the JAK, but then the JAK has all these, black box or whatever kind of warnings. And so, how does that conversation go with, especially with conversations about children on these medications?
Great question. So that's one that as a pediatric allergist and immunologist, I am kind of front and center as far as my heart. And so I think that one of the reasons that I want to make sure that I address the elephant in the room is that I have to address this elephant in the room whenever I'm kind of recommending any of these different processes, because pediatric patients are going to prefer an oral medicine over an injectable every day of the week. And so talking to parents, because the child is probably not going to think about what their cardiovascular risk factors are whenever they get to be over the age of 55, but mom is. And so I have an open and honest discussion, and I take the history. I make sure I ask, what are this kid's risk factors? And I do have a handful of patients that decide to go with the oral JAK inhibitors, and they are they're happy with it. But it is something that I do. I always try to make sure I disclose everything, and I talk through everything. Say, hey, these are the risk factors. What is your specific individual's risk factor? So how do I actually approach that one?
Okay. Let's see. I'm trying to see. I think that was kind of all of the questions. I'm just curious, since there's different phenotypes of eczema, is there sort of a rubric that you go through in order to make that decision with conversation with patients, or is that still sort of a work in progress?
So I'm a big believer in kind of making sure that I'm assessing kind of their adherence, making sure that I'm assessing what are our irritations to our skins that we're doing. How often are they using soap? What kind of soap are they using? Are they using fragrance? How often are they actually moisturizing? Because my teenagers, universally, they don't like to use moisturizers. And then, are there ways to use different preparations? So people who don't like that greasy feeling with ointments, cream would be a better option. And right now, some of it, as far as the systemic therapies, is dictated by what hurdles you actually have to jump through from an insurance side to get something approved. And so there are going to be those aspects. But traditionally, I kind of, if I have somebody who has failed a topical corticosteroid that is medium to high potency and has failed one of the other, either the topical calcineurins or the topical phosphodiesterase 4 inhibitors or the topical JAKs, that's whenever I start talking about systemic therapy. And I try to kind of bring that discussion earlier, before whenever I'm thinking about it, even a step ahead of that encounter where I'm going to actually kind of talk directly about it, so I can make sure that I kind of do my due diligence and have them read about it, because then we can have a more thoughtful conversation. It's hard in that moment where you feel like you need to start a therapy and you haven't given the family time to think and ask questions. And I think the power of follow-up is a really important aspect, to give them time to kind of raise their questions back to you and say, hey, we talked about this a month ago. Let's keep talking about it.
Okay, well, thank you for answering that question too. And thank you for your time and attention, everyone in the audience. Really appreciate you hanging in there. Just about everybody stayed. So, so with that, I'm just going to say thank you. Have a good night, everyone. Look for that follow-up email. Thank you for joining us. And thank you so much, Dr. Dunn. Really appreciate it. Bye, everybody.